CHEVAR, FEVAR are part of the new technology to treat the juxtavisceral and thoracoabdominal aneurysm. It's a real step forward in the endovascular aortic technique, but it's a very precise procedure which needs experience and collaboration. I would like to thank again and again Dr. Petrov. He's a courageous man. We know him internationally, and he is bringing to Sofia the best technologies that you can have in your country, because he knows a very large number of people and learn from them. And we learn from him. Congratulations and thanks, Ivo, for your kind invitation. Just remember of my society that I was pioneer of with Dr. Busquet on the left side of the screen, Dr. Dietrich on the right side. They both died too early for me, and your servitor in the middle with the same glasses. So the chimney endovascular aortic repair, acronym CHEVAR, is something that you can see on the diagram. Two stent grafts introduced by the axillary approach or brachial approach coming down and joining a graft coming from down, from femoral, to treat juxta-renal and two short necks in the new technology of FEVAR. It's a sort of breakthrough. If you can look carefully on your left part of the screen, you can see gutters. In French, gouttière. It's usually used for the rain on the roof, but here it could be a problem. Let us go on. So, antiguade approach from the top to treat the renal. So you need to be two practitioners, one at the head, one at the foot, and with a good collaboration between both of them. And you join you at the renal level. It's a combined procedure. It takes more time than usual. You need a very good radiologic system. You can do that on a simple, very simple artisanal C-arm. You need to be in a hybrid room if possible, if you need to cut down, for instance, in the humeral or in the brachial artery. This is what I just said on this diagram. It's still a complex procedure. You have more complex, but this one is complex. Don't start, if you are a beginner, you start with a proctor and don't start alone in such a procedure. The problem of gutters. It's a way to have an endoleak, type 1, so it's a problem. And this gutter here, gutter on the right side, are open space that can lead to an endoleak. So what's the treatment for that? Nothing really. It's only optimal graft sizing strategy. You have to look exceptionally well to your selection of graft. If not, you try to be helped by your cell rep. Dr. Armando Lobato from Sao Paulo, some people are friends with him. I think, Klaus, you know him well. I know him well. They have very bad time with the epidemic in the country, so his meeting has been cancelled during 2 years in a row. But he was inventor of this kind of sandwich technique. This is the second name. It's not only a cheminée, could be like a sandwich. Sandwich are good for the break. They are good also for some patients, especially if you treat and want to save an iliac internal artery. And this person, this surgeon, I don't know who exactly, maybe you know him, Klaus, he went to the extreme expression of the cheminée technique. Look, a very long thoraco-abdominal aneurysm, and he put 3 stents, 3 grafts in the system, aortic system, with 2 chimney in the renal. I think it's an extreme expression. So don't do that immediately if you start your program. Let us see the evolution of stent grafting. This is the branch aortic graft. This is a complex procedure too, open only to selection of center and excellence, center of excellence with experienced surgeon. First fenestra graft attempt was made by Rob Greenberg, and unfortunately died also early of cancer, pancreas cancer, in Cleveland, US, with the Cook group. This is the emergence of the technique going potentially high during the last few years, exponentially high. So you need a dedicated planning software. It's a complex procedure to put in place, very complex procedure to put in place. If you miss your sizing, you miss the operation and you miss your patient. So the standard fenestrated graft have a variety of length made of composite graft, big or small fenestration, sometimes a scallop, including one or 2 arteries. The early London experience was very useful for all of us, especially brought by Dr. Thompson, Matt Thompson, who is now involved in the commercial system of some graft, but he was a very good private and public surgeon in London, St. George's. And the mortality was immediately not too high. 30-day mortality between 2, 3, and 10, depending on the way the study was conducted. And compared to the open aortic repair, there is an advantage for sure, as you can see on this slide. The problem of this technique, in my opinion, this is the renal failure. The renal failure could come from increase of amount in the contrast media, could lead to dialysis, or breakage, or misfitting of a renal endograft in the fenestration. So renal is a weak point of this technique. So the initial commentaries were a safe alternative, not an alternative, but more follow-up needed. Classification by the best team, and always to be organized in a team. So many other publications have been made here. Dr. Hollon formerly in Lille, north of France, now is practicing in Paris, Hôpital Marie Lannelongue, near the center, near my hospital, Val d'Or, by the way. And they did at the beginning a study of the French centers, public. So you see, says 16 French academic centers, more than 100 patients. The target vessel, superior mesenteric artery, renal artery, for a total of 400. And some problem. A distal implantation of constant and occluding the renal branches, bad implantation, failed catheterization of tight renal osteostenosis, which is a problem, and failed catheterization of celiac trunk. So, even if there is a good patency, some problem can happen. You need to be very technical. And it's a long procedure, sometimes 1, 2, 3, 4, 5, 6 hours. With a lead apron, it's long and you have to be strong. Early result, you see some dialysis patient and some failure. So it's not panacea. Follow-up, some mortality, 12, but other causes. And you see an honest, anyway, follow-up. So survival rate is acceptable. And also, you can see anatomical change in the size of the aneurysm called shrinkage. So it's still a productive technology, efficient and safe, I should say. The conclusion of this initial study was you do only high-risk patient. You need a real learning curve, should be reproducible. There is no homogeneity of the literature, so could be improved. And should we do that for short neck? We will discuss later of that. So some example, some images to let you know the difficulty and the technicity of the technique. This is a type 4. Look to the business. There is a lot of things to do. You can't do that by yourself. You need to be helped with one other doctor at the top of the table and 1 or 2 assistants and 1 or 2 nurses. And you have to put 100, 150 or 200 cc of contrast media. You have to be followed by your anesthesiologist and rehydration for the patient, absolutely necessary. So this is the result of the branch. So in the CUT study, if you order a graft made for your patient, tailored for your patient, sometimes you have to wait 1 or 2 months to be delivered. So be careful when it's an emergency case, you will be able to work with the surgeon directly with that endovascular procedure. This is the result, nice result on the system, but long procedure. This is the experience and the table, as we see. Hollande did a good work and is a very good surgeon in Paris, practicing well in that sort of patient. But remember one fundamental thing, the spinal cord ischemia. So they do a drainage with new system to be under good pressure. You have to keep a good pressure, blood pressure, to avoid paraplegia, palsy, or sometimes more, and sometimes sequela. This is the problem of the procedure, so you have to choose a very good selection case. Hollande still working on it. The mortality of, you see, sometimes higher than expected, especially few years after the beginning. So it's an innovative technique in progression, still in progression. There is competition with the surgery. Joseph Coselli, maybe some people have heard of his name, is a successor of Dr. De Bacchi or Joe Coselli in Houston Methodist. They are very used to the surgical technique. We need some follow-up in order to broaden the indication. Highly specialized center, as I told you in the beginning, with a collaborative team, and you have to look to the price. And if your medical system, national medical system, can reimburse this graft, which in France are about 20,000 euro or 30,000 euro. Is this the same in Germany, Klaus?
Yes.
Okay. I thank you for your attention.
So congratulations for this lecture. Comments, questions from the audience?
Yes, we are very happy that we have this technique naturally. Yes, but the intervention time, it's with a simple EVAR. I have done my fastest in 45 minutes from the beginning of
EVAR.
When
and
you
how
look
long do you do
at
for
FEVAR,
this?
Then you have easily 2.5 to 4 hours.
It's what I told. I agree with you.
And you have up to 1 hour of fluoroscopy. So that is also a high radiation dose, not only for the patient, but also because there's scattered radiation, so also all the interventionalists. So I would not like to do every day a FEVAR, yes, and even with good protection, there's still something going through.
In the floor, who is doing this technique? Tell me.
Mai recanalizirах. Дайте ga došli фаном по същия начин.
Nobody yet.
Yes.
So what is your impression regarding the renal zone and the weakness of the branching, weakness of maybe misposition? I think this is a problem. And the time long, the time, this movement, can they be acceptable in the time? Klaus.
Yes, we accept it because the alternative is an open surgery with also some complications because that are not healthy people. They have a lot of comorbidity. Yes, and so you have to make a decision, yes, individually, I think, yes.
Do you select your sizing by yourself or with the help of the company?
We give the CT data on a disk to the company and then we get it.
Because if you consider a company, and by the way, thank you for the company to organize this sort of meeting in support of EVO. The company have the experience of 1,000 cases because they serve all the country, and we have the experience of 20 cases during 1 or 2 years. So you have to feel confident with your company, but choose the best. And I think this kind of technique are only devoted to one. It's only Cook, I think. Do they have no other?
Yes, there are also others, yes, but Cook is perhaps leading, I think, at the moment,
leader.
at least. Yes.
But I don't want to make any marketing for them. And do you admit that it's a long period of waiting before getting the graft?
Normally we wait 1 to 2 weeks.
What you say to your patient? You have to wait or?
Yes, we inform him. Naturally, we discuss that with the patient, the options of treatment, and then we say, yes, we can do it with access via arteries, but without opening your abdomen.
Tell me, if there is an emergency, what you do?
But when it's an emergency case, yes, you can only do open surgery is one option, or the other chimney technique. You can try that. Yes, you bring in a catheter with a large balloon, and you block the flow.
Sorry for interruption, but we are in
the
front of time, and
I have a last question. It's very important. What is your impression on sheep neck technique? 30 seconds, please. Sheep neck technique.
Yes,
what do you
I
think?
would prefer the fenestrated technique, yes, but when it's not possible, chimney is
inevitable.
Yes, it's an option.
Thank you. I'm sorry.
So